gentlemen. So I welcome you all to this instruction course titled Controlling Myopia Progression, Turning the Dream into Reality. As we all know that myopia is increasing at a very rapid rate. There is an immediate need for all medical practitioners to include myopia control measures into their clinical practice. So with this purpose, we have come together with this course. I am Colonel Shrikant Vaikar, so I'll be presenting the concept of myopia control, and finally I'll be concluding with orthokeratology, the final talk. So we have Dr. Kavita Natarajan from Shankar Netralaya, Chennai. I would request you to please join us on the podium. She's from Shankar Netralaya and she would be speaking on myopia control strategies. We have General Sagarika Patyal ma'am, a very senior ophthalmologist from the Armed Forces, and presently she is the senior consultant in Center for Sight Group of Hospitals at Dwarka. She'll be presenting on lifestyle modulation for myopia control. Then we have Professor Jaspreet Sukhija from PGI Chandigarh. He'll be speaking on pharmacotherapy of myopia. And we have Dr. Rishikesh Mai, ex-fellow Shankara Netralaya and presently founder-director of Avdut Netralaya at Nagpur. He'll be speaking on optical control of myopia progression. So without wasting any time, I'll go on to my talk. Could you, next slide is not progressing. That slide is not progressing. So I bring to you greetings from all of us at Sitapur Eye Hospital. If you visit any school or a college, this is the common picture that you see. Most of the children wearing glasses. And this number is only increasing by the day. The world is experiencing an exponential growth of myopia. It is estimated that by 2050, almost 50% of the world population would be affected by myopia. 10% of which are likely to have high myopia, leading to a tremendous socio-economic burden. Exponential growth of myopia is being witnessed in East and Southeast Asia. India is not lagging behind, and the West is also catching up. The European Eye Epidemiology Consortium has demonstrated a dramatically increasing prevalence in the age group up to 25 years. This slide depicts the march of myopia. You can see an almost vertically rising curve in the prevalence of myopia in Hong Kong, Taiwan, Singapore, and South Korea over the last few decades. So if you look at the natural history of myopia, we all know that myopia appears around 4 to 5 years of age, slowly increases up to 10 years, and then matching with the pubertal spurt, it increases rapidly and almost linearly, finally stabilizing around 20 years of age. And what do we offer as ophthalmologists? We counsel the patient and the parents and tell them not to worry. We say it's a normal for myopia to increase, and we'll perform refractive surgery once the myopia stabilizes around 20 years. It is as if we are allowing the fire to spread before trying to douse the fire. It's high time that we think differently. If we have to control myopia, we have to act on the rising phase of the myopia. Myopia provides us with a big window of opportunity of almost 15 to 16 years to act. We just have to find some ways and means to flatten this curve of myopia during this period. For a moment, I'll take you back in history. We all know, if you look at the history of cataract surgery, we all know that the first surgery was ECCE in 1745. And then came ICCE in 1773. ICCE immediately became popular as it gave complete clarity of vision at that time, and the entire focus of research shifted to ICCE till it was toppled from its pinnacle of popularity by the coming of intraocular lens. So when we look back today, we realize that for almost 200 years we were on the wrong path. Today we are in the era of refractive surgery. The entire research is going into refining refractive surgery, despite knowing the fact that it can be offered only in patients beyond 20 years of age. There's a big vacuum in the modalities of treatment which can be offered below 20 years of age. And there's an immediate necessity of more research in this area, lest our future generations would look back and say the same thing for us. If we have to control myopia, we need to understand as to why myopia increases. The most potent stimulus for progression of myopia is a peripheral hyperopic defocus. As a result, the eyeball tends to increase in size to bring this image into focus onto the retina. It can be compared to phototropism as seen in plants. So to control myopia, either we can make the sclera strong and prevent globe expansion, or simply convert this hyperopic defocus into a myopic defocus. Based on this concept, various myopia control measures are in vogue. These are lifestyle modifications, increased outdoor activities, progressive or bifocal glasses, soft bifocal contact lens, orthokeratology, pharmacological measures such as low-dose atropine, and myopia control glasses. All these would be covered by the next speakers. I'll just touch upon the various modalities which are under investigation at present. 2% pyrazipine gel is a selective M1 receptor antagonist. It has all the beneficial effects of atropine in myopia without any of its side effects. Scleral collagen cross-linking is being investigated. It is similar to C3R as we do in keratoconus. Scleral collagen cross-linking aims to strengthen the sclera and prevent globe expansion. Dopamine levels have been found to be decreased in myopia, and dopamine is said to have protective effect in myopia onset and progression. Melatonin levels are found to be increased in myopia. It may be due to alteration of the circadian rhythm, or maybe it has a causative effect. It's yet to be known. 7-methylxanthine is an adenosine antagonist. It makes the sclera strong by collagen deposition in the sclera. Oral supplementation is available in Denmark, and it has been tried in children in 400 milligram in various doses once a day, twice a day, and thrice a day, and it has been found to have a dose-dependent effect in controlling myopia progression. Increasing role of RPE is seen in releasing growth factors regulating scleral modeling. Repeated low-level red light stimulation is coming in a big way. Only 2 days back there was a talk in this conference itself, and they have shown to be very effective not only in controlling myopia progression, but also it has caused regression of myopia by few diopters in some cases. So we are likely to have some newer modalities available for us in clinical practice in the coming days. So control of myopia progression has become a reality today. There is sufficient evidence in literature to show the efficacy of orthokeratology and atropine in slowing down myopia progression, and the newer modalities are also coming up. If you look at this slide, it shows the rate of myopia progression, which is expected in Indians to be 0.27 to 0.4 diopters per year. In Caucasians, it's 0.5 diopters per year, and in East Asians, up to 1 diopters per year. And this rate is brought down to 0.1 diopters per year by orthokeratology and 0.15 diopters per year by atropine. So we have to have a holistic approach towards myopia. Whereas in the rising phase, we have to introduce myopia control measures, and once myopia stabilizes, refractive surgery is always there. So if we are able to suppress this curve of myopia and limit myopia to manageable levels, say to about 1.5 to 2 diopters, it will not only reduce the burden of high myopia in the community, but will also be beneficial towards delaying presbyopia. If we are able to bring this, It will be one small step for man, but a giant leap for the mankind. Thank you. I'll now call upon Dr. Kavita to present her talk.
I thank Dr. Srikanth sir for this great opportunity. And like cataract, now myopia has become really a well-researched, very much talked about and very much practiced and sadly mispracticed also all over the world, not just among pediatric ophthalmologists. So we want, as pediatric ophthalmologists and people who deal with children with myopia, to give some insight on how to approach if a patient or a child presents to us with myopia. So I'll just briefly go through how we as in an institute and how we should approach patients with myopia, like to reduce the burden of refractive surgery or at least bring the children to the level where refractive surgery at least is possible. That's what I tell the teens. If you want laser to be done for you, then you should control your gadgets and things like that. That kind of works. So this is what I'm going to try to explain. So there are some definitions we need to know when we talk about myopia. So what is primary myopia? So there are myopia which can be due to a lot of other conditions, and not all are amenable to these kind of measures that we are now talking about. So it should be primarily a primary myopia where myopia is not due to any cause. So it is either an axial myopia due to longer axial lengths or a refractive myopia due to changes in the refractive structures like cornea and the lens. What are naive myopes? Naive myopes are myopes at initial presentation. So they can present with -0.5 spherical equivalent. They can present with 2, but at presentation when they are diagnosed first time as a myope is when we call them as naive myopes. What are pre-myopes then? So a refractive state of an eye with less than plus 0.75 diopters, we kind of call them pre-myopes, especially in the background of family history of myopia, siblings with myopia. So they are kind of children where we should really pay close attention to. So they are called pre-myopes. So some more definitions. What is progression? So any change in axial length and refraction over time which can be demonstrable at a period of every 6 months or 1 year, we call it progression. And progressors are individuals with the mean rate of change of myopia exceeding 0.5 diopter per year or greater, and with corresponding axial length elongation of 0.2 to 0.3 mm per year. So progression in spite of treatment is a term now when failure of a chosen myopia treatment strategy to control axial length elongation happens. And cessation of treatment is again a thing which is still a big question. Nobody really has a consensus. So we don't know whether up to 18 we keep on doing or what. So when a child or a patient presents to us with myopia, so these are the things that we have to do. A baseline evaluation. History is important. Parental, family, onset of myopia. Behavioral practice is extremely important. Outdoor versus indoor, near versus distance activities, very equally important. Refraction, of course, whenever indicated, cycloplegic, central and peripheral refraction. Best corrected visual acuity, both eyes. And binocular status. Accommodative function tests, virgin function tests is important as part of myopia evaluation. Anterior segment and IOP to rule out other causes if present. Corneal topography sometimes can be done as a baseline, but not necessarily in all situations. And axial length measurement if you are going to treat myopia eventually. And fundus examination and imaging to document fundus changes if required. So when we say myopia, what are the risks of myopia? So there are some things which are called myopia inducing things, which is a 2% proven increase risk every extra hour of near work per week, any age. So lower vitamin D level is a controversial thing which sometimes can be inducing myopia risk factor. These are all patients who do not have myopia yet. Myopia protective, so as a corollary, yes, 2% reduction for every hour outdoor can have a positive protective effect on onset of myopia. So increased even indoor lighting can be protective for myopia in some context. So risk of progression is when there are already myopia as onset. So higher baseline myopia as compared to lower onset at the time of presentation. Younger age at presentation. Girl child has some more increased risk of progression. Excessive near work, of course, is well established. Reading at shorter distance, like we keep having parents tell us to read at a good distance, that is really extremely important. Parental history of myopia. Asian ethnicity, of course, again well proven. And defective accommodation and convergence, which sometimes we don't really look into this, but defective accommodation convergence, the combination complex is very, very important, and it can be a trigger for progression. And high AC by ratio, accommodative lag, because these situations children accommodate more and myopia can progress faster. And near esophoria, again to reinforce that good orthoptic evaluation is a must. So how do we stratify? What are the risk stratification tools? Are there any way to know, like if a patient presents, what to give or when to give? Or how do you assess? How do you tell the parents? Is your child going to, what will happen 10 years from now, 5 years from now? Is there an objective way to know? Yes, people have tried to study that. So there are some calculators called the Brian Holden Vision Institute calculator, which is online. So you feed in data like age, refractive error, ethnic data with and without treatment graphs. It gives you, if you treat myopia, what happens in the next 4 or 5 years. If you do not treat, what happens. So we can kind of give a guideline to the parents and for ourselves and then initiate treatment. Like there are similar models with Chinese data where behavioral and environmental risk factors are included in the data, and you can give a guideline on what is going to happen if you don't treat. Like preceding myopia onset risk indicator, UK based, again you take into age, spherical equivalent, axial length, parental myopia. And myopia progress and risk assessment score, where you can classify children as at risk and low risk and can be differentiated to decide on what modality we can suggest. Ultimately, individual private practice, our practice choice or what works best for us could be the best guide if you don't have all these strategies. So how do we approach a myopia? What are the strategies? So first is, of course, to create awareness. Second is screening the potential population to catch them early so that we can intervene early. The targeted population could be premature children, siblings and children of myopes, and children with excessive near work and less of outdoor activities. These are potential targets. So initial myopia progression control treatment. So when do you initiate a myopia progression control treatment? So there is still no consensus on appropriate timing. Do we start at the first visit or what do we do? The above mentioned strategies can be applied to calculate whether they are at risk or low risk or high risk. Early intervention for patients with multiple risk factors like sibling history, parental history, close near work, outdoor activity less. So current recommendation is, in many situations, we start some form of myopia control treatment at the initial presentation itself in select patients. So how and what to choose? There are so many things now we are having. Some of them are saying glasses, some of them are trip-ins. How do you choose? So there are spectacles, progressive, bifocals, ortho-K lenses, contact lenses. There is n number of this. So each speaker is going to tell us exactly how they work. But I'm going to rush through the types. So single vision glasses, most popular, very affordable, well accepted and tolerated. Under correction used to have some role, but now it is kind of not indicated. In fact, it's contraindicated. Bifocal glasses can reduce accommodation demand, and children with near esophoria and can benefit to some extent. Prismatic bifocals can also be tried. Progressives have been tried similar to bifocals and have noted control of progression of myopia. And now the current go-to glasses is the DIMS glasses, like defocus incorporated multiple segment spectacles. There are several options from this which we can choose. Significant retardation of axial length elongation in 8 to 13-year-olds have been well demonstrated. Comparable or superior to all other modalities except probably atropine, which is still superior. More useful in peripheral hyperopia if it is documented. That is where peripheral refraction comes as an important tool for myopia evaluation. And limitation in myopia limitation is when you have myopia between 6.5 and astigmatism less than -4, these glasses are effective. Beyond that, we don't have still options. So contact lenses as an option is not that popular in India because of climatic conditions, compliance and as such. Can be used above 7, especially children who are inclined to sports, daytime sports. This contact lens I mean by day wear contact lenses. There are other type of different types, soft single vision contact lenses, no appreciable efficacy in controlling myopia progression and risk of infection is there, so it's not very popular. Dual focus contact lenses like MySight contact lenses are getting popular. Myopic peripheral defocus it is based on. 8 to 12 years of age is ideal age when they are more inclined to sports and all that. And significant control of spherical equivalent is demonstrated, quite safe because daily disposable options are available, but costly. Ortho-K lenses is really effective in a very select group. Night wear contact lenses, so you don't have to wear in the daytime. Myopia control is achieved in higher initial myopes, especially more than 5.5 diopters, and it controls axial length prolongation. Rebound effect and risk of infection is again a negative factor. So atropine is going to be talked, extensively researched, most effective till date, widely used, 0.01% and 0.05% are the commonest used. Ideal to start after demonstrating progression and not at the initial presentation. Ideal age is above 6 and very safe, no consensus on how long do we continue. So follow up every visit, ideally 6 monthly, and you repeat all these tests to know the effect of the progression. So the algorithm will be myopia at presentation, baseline evaluation. If there is a low myopia, low risk, single vision glasses, lifestyle changes and close follow up, you don't need to start a myopia control method. If there is a high risk with family history and everything, all above, other than that, you can start on DIMS glasses. If you continue these patients and there is no progress, as long as no progress, you continue the same and follow up every 6 months. If despite this there is progress, then you switch to LDA and follow up. And if despite that there is progress, you do a combination of LDA and DIMS. If despite all this there is progress, then we call them as non-responder and decide to stop. If it is moderate myopia at presentation, then you can start with DIMS glasses, lifestyle adjustment, close follow-up, and rest of the follow-up continues. If there is progress despite that, you switch to LDA or add a combination. So this is how we kind of form an algorithm. So duration of treatment, like I said, there is no consistency, there is no consensus on how long to do, but 1 year to assess efficacy, whether to know whether myopia is actually the control measure is working, and minimum 3 years, whatever treatment you have started, you can continue before you decide to either continue if it is responding or discontinue if it is not responding. And cessation after 16 years or if there is failure to respond. And tapering if LDA is used, because there can be a rebound even in very mild LDA. So like I said, there is no clear guidelines yet. Reasons for failure is compliance related is the first thing, especially with LDA. You can switch to other modalities. Not adherent to lifestyle adjustments like near activity and sunlight exposure despite using the myopia control progress measure is another reason for failure. Ethnic reasons can be a reason, genetic predisposition, but sometimes we don't know why children don't respond. So this is a very good systemic review meta-analysis which everybody can go through to form guidelines on how to treat these patients. To summarize, myopia is easily the most researched eye condition in the recent past in children. Awareness has tremendously increased among patients, among parents come and ask us for the treatment. It is also the most mistreated condition in the recent past, so it is for us as pediatric ophthalmologists to guide the parents of what is suitable for the patients. And despite everything, we can now say that myopia is now a treatable condition even in children. Thank you so much.
Thank you, Dr. Kavita. I would now request General Sagarika ma'am to please come and present her talk on lifestyle modulation for myopia control.
Thank you, Colonel Vaikar, and thank you, delegates, for being here in the early morning session. And I'd like to tell you that actually myopia is nobody's baby, and that baby belongs to all ophthalmologists, but I would go beyond that also. Myopia is a condition which belongs to society, and everybody has to learn how to deal with it, because if we all don't join hands, we are not going to be able to surmount this problem. So let's go in through it. So we know about the incidence of myopia because Colonel Vaikar has already talked about it, but we must understand that this condition is not just in urban India. Rural India has already started running, and it is leaping forwards, and therefore we have to control it both in India, in rural as well as in urban areas. Now we have to understand the first thing that is to be done, which already Dr. Kavita has talked about, is spectacles. Now, when do we start the child's eye examination? At the very earliest, when the child goes to school, go ahead, take the child and get the first eye examination done. Do it at all ages. And it is not just that the parents, but it is parents, Teachers are extremely important people who should care for the children and see to it that why the child is not being able to do the homework properly, why is the child always wanting to sit in front, why is the child not performing well. All this may be just one reason, and that is myopia. And therefore, we have to ensure that the child is wearing the correct spectacle correction. Oftentimes parents come with the spectacles which the child has been wearing for the last 5 years and has not been checked. That has to be when the initial onset when the child comes. At that time, the parent has been told, please come for your 6 monthly checkups and review and follow up. We must know that there should be access to newer modalities of myopia control. Generally, people just know that only glasses are available, but there are so many other modalities which people are going to talk about. And then we all realize that if we give correct vision, it will enhance a child's academic performance, improve self-esteem and his quality of life, his social conduct. It will decrease his anxiety level. You've all heard of Helen Keller, where she was a child who could not see, and therefore she went into a severe state of anxiety and nobody could control her. So that's what blindness does. I'm not saying that myopia does this, but definitely it puts the child under a severe state of anxiety. In 2015, I was in Leh, where we had conducted an eye camp in a school called Lambden School. And in this school, we were able to measure just simple measures, check the vision, check with a direct ophthalmoscope, have a look at the optic nerve, have a look at just the eye pressure by non-contact tonometer, and along with that, then all the students who could not see, we took them to the hospital, did a proper thorough cycloplegic checkup, gave them the glasses. Glasses were not available at Leh, so we got them across from Chandigarh and offered to them free of cost. So this is very important, that we must look at the economy of the patient. Can the patient afford it? Can the parents afford the classes? Try to arrange for it. It is not just merely we tell the patient, go ahead and make your glasses. We have to see, can the parents afford it? Along with this eye camp, we could see so many other types of lesions which we found in young children in Leh. Now, what are the problems spectacle use? You give us spectacles to the parents. One is the economy of it. Second is the children are teased by their peers. Chishmish bolte hain, kuch bolte hain. Now that is very detrimental to the child's, and it raises the child's anxiety level. Therefore, there's a need to change the behavior pattern and habits of elders and youngsters by just explaining to them about what is myopia. So parents, teachers, playmates, classmates, society needs to be sensitized to the mental trauma that the children face on being the butt of jokes and being called varied names. Healthy interaction should be there between the healthcare professionals and school children and all members of society. Habit modification in accepting spectacles as a very, very normal thing amongst the young and old and all members of society will prove to be a boon for improved acceptance of children. What are the barriers for spectacle wear? Nasal scars, unattractive frames, susceptibility to ocular injury, lack of parental involvement, stigma of wearing spectacles as perceived by society. Mother doesn't care whether the child is wearing glasses or not. That's not of use. The mother has to care, the father has to care, the siblings have to care. What are the solutions? Give them attractive frames, lightweight, trendy, educating both the children, the parents and the teachers for regular eye examinations, change the glasses whenever the spectacles are required. And good will definitely improve the educational performance of all the children. Now, there are many causes why children do not wear the glasses. Broken glasses, broken frames, being teased by their friends, lost spectacles, disliking spectacles. What are the very important factors? All you need to do is to take the child outside and play. Now, in Bengal, Rabindranath Tagore had these fantastic, and you've all heard of Shanti Niketan, where he used to have classes outside under the trees. That is what we are saying. That do all, whether it is activity, just sitting down, reading, whatever, without a mobile, but just take your books and read over there, enjoy the fresh air, because that is going to help. The sunlight is going to be your greatest benefactor. Exposure to increased daily light decreases the axial growth. And the high illuminance is effective in preventing the onset as well as progression of glaucoma. This has amply been seen by various studies. Bright illumination stimulates the vitamin D synthesis, exposes the eyes to a very even dioptric landscape of a typical outdoor scene, short wavelength ultraviolet light, and also helps dopamine release. Now, I'm not going to talk a lot about dopamine, but we must remember this, that dopamine is extremely important because it is helping us, it inhibits the ocular growth, it helps the anchoroidal thickness, and because it releases certain triggers, neurotransmitters like nitric oxide. So I know others are going to talk about it, so I'm not going to go into details. Now, wonderful thing what China did, they brought out strict guidelines because I said society has to change its thinking about myopia, so about the smartphone usage. Now, you see many children, many parents, what they do, they just give the a mobile to the child in the form of a electronic pacifier. And the child keeps on enjoying, not realizing, the parents don't realize what harm they are doing to their own children. So China has brought about certain modes by which they are going to protect their children, and we also need to talk about it. Habit modification for all people in education. So every person, we know that teachers give their homework in mobiles, teach in mobiles. Now, learning is very good. It was very good during COVID times, but it is not good now because it has certain drawbacks, because it imposes the additional use of mobile phones and near work, which may result in increase of myopia. And what about habit modifications? You know, all of us have this terrible habit of taking the mobile and then having a look at it. And in fact, some of the children, in order to escape parental supervision, they go underneath the blankets and they keep on looking at the mobile. And just mind you that this suppresses the melatonin release, which is responsible for circadian rhythms. This problematic cell phone use, PSU, results in poor sleep, mental health problems like depression, anxiety, poor quality sleep. Just imagine how it is affecting our mental health. So insufficient sleep hours, poor quality sleep have been associated with greater myopia. Near work has already been talked about. Please let us all understand it definitely, near work, constant near work, continuous near work will definitely help in elongation of the eyeball. And what Sheeman has said, that myopia may potentially stabilize by the age of 15 years if it is associated with less, the captive word is less near work. And Bulliman and Mulimo and colleagues, they have talked about SPAN, that is the highest risk factor for myopia progression. And this is one thing that I would definitely like to talk about, that it's not merely children, it is also adults. That is, extensive near work causes higher increase of progression of myopia. And even they've found that the US National Research Council Committee and Vision Group, right, in working groups in myopia, they have found that up to 40% of low hypermetropes and emetropes joining universities and military academies were less likely to become myopic by the age of 25 compared to 10%. The implication is basically that environmental factors affect myopia development. So therefore, high levels of near vision activity, if you combine it, near vision, combine it with outdoor activity, where it results in significant reduction of myopia. Now, natural light is so wonderful because there's been a huge studies have been conducted where they have found that longer duration of exposure to moderate outdoor light intensities exerted on myopia, it has preventive effects and fewer side effects after being exposed to intense light. So what is important is the intense sunlight that we are able to face, and that helps it. Now, artificial light also can help us. Artificial light, it artificially increases in light exposure can also reduce progression of myopia, which has been demonstrated by using light therapy glasses in young adults. It results in a slightly thickened choroid. Now, just remember, it is these LED bulbs which we must tell the parents to be very careful about. There have been young children who have landed up with myopia because of the excessive use of LED lights. Let's look at smoking. Smoking is awful for so many health diseases. But did we know even that second-hand smoking can also affect the progression and also the onset of myopia? Nutrition and myopia, we really don't know very much, but definitely we ought to advise our patients to take a wholesome diet. And she has already, Dr. Kavita has talked a little about vitamin D, etc. But we must understand that myopic children had lower intake of energy, protein, fat, phosphorus, iron, cholesterol. Studies have been done all over the world, and they have realized that taking a wholesome, good diet, and I think a huge dose of sunlight will definitely prevent the onset as well as prevent the progression of myopia. Thank you so much.
Thank you, ma'am, for a wonderful talk. I'd now request Professor Jaspreet Sukija to present pharmacotherapy of myopia.
Very good morning, everyone. First of all, I'd like to thank Colonel Vaikar for this you can say, a very wonderful IC where so many people are interested. I mean, it's the last day and it's a hot topic really because, I mean, the mobiles are everywhere, the stress of near work. I mean, people just want to, the amount of the competition which is there in India especially, so it's a lot of near work which is happening, and now gadgets which are coming up. So it's all being done on iPads, mobiles, children playing games. So a lot of issues coming up, and really it's becoming the next pandemic. So that's the reason we need to know how we can prevent the axial elongation of the eye, so that you can prevent the complications which can occur later in life. So as is already been discussed, the methods to control myopia progression. So I have no financial interest in any part of this atropine which I'll be discussing. So the environmental modification, very beautifully covered. You have pharmacological therapies which I'll be talking about, and then you have the optical corrections, which again would be dealt with in another presentation. So basically what we have in pharmacological therapies here, what has been done over the years, what had been studied, so many trials have been done, is what we know as atropine eye drops. So they've been shown to be quite effective in slowing the myopia progression. However, we don't know the mechanism as well. They just proposed theories. It acts on the sclera and reduces its remodeling and elongation. It binds to acetylcholine receptors on amacrine cells. Obviously, really increase the dopamine release and inhibitory effect on the eye growth, or it could have an anti-inflammatory effect. So these things are not really clear because it's been effective in you can say chicks as well who do not have any accommodation. So the accommodation theory really doesn't hold true in that case. The other drugs under evaluation are just being discussed: parinzapine, tropicamide, hyoscine. Well, no RCT is done. Then there are dopaminergic drugs where human studies are not available. Even in these anti-inflammatory drugs and IOP lowering drugs, we don't have any human data as yet. So what we have data for, and which have been tried and tested and shown to be effective, is atropine. Now the most common concentration which is used is 0.01%. That's widely available in the market. But there are trials which have been done with higher concentrations ranging from 0.025 to almost 1%. And what did they see? So basically, I'll be talking about 0.01% mainly, but I would cover the higher concentration as well. So most of the RCTs which have been done, if you see, this is the mean annual refraction and the axial length. So these are two things which are important when you deal with any case of myopia. So what happens is these circles are showing the number of patients who have been enrolled, or number of trials which have been done. So if you see the atropine 0.01%, probably the maximum number of studies have been done, and this is the thicker line which shows so many trials have been done, the randomized studies have been done as compared to other concentration. And similarly is the case with the axial length. So most of our knowledge is about 0.01% atropine in preventing the progression of myopia. So how to select the concentration of atropine for clinical use? Well, it should be effective in slowing myopia progression. It should be well tolerated by the patients with least side effects, and of course should have minimal rebound on stopping treatment. So that's another important thing. So the first study was with 1% atropine. So it's a high concentration atropine. They had shown good efficacy, but the problem was this high dropout rate because of the side effects of photophobia. So everything is not just one direction. You have to see what are the side effects and how comfortable the child is. The other concentration, well, they lowered it then to 0.5, 0.25 and 0.1%. And this is again an RCT. So I haven't taken the studies where the RCT was there. Probably these are the important studies which have been done. So over a period of 2 years, they did show you can say a dose-dependent myopia progression decrease with the maximum in 0.5% as compared to 0.1%. So you can see just 0.04 versus 0.447. But the problem was the 22% side effect in the higher concentration group. So, and there was no placebo or axial length data in these studies. So probably it was not that important. So the ones which have been made a significant impact over a period of time are the ones which started with The first one in Singapore by Chia et al. That was the ATOM 2 study. Then the ATOM 3, you have the LAMP study, the CHAMP, and this is the Indian study done by the AIMS group. So where they shown a good effect with 0.01% atropine. So considering the progression of myopia on 0.01% atropine, because that's the most widely studied drug. So in the ATOM 2 study, what they had was a rapid progression. So we would call it more than 0.75 diopters. That's almost 1 diopter. It was 18% in 2 years. And in the LAMP study, again, it was 28% in 1 year. So there's a lot of progression occurring despite using 0.01%. So in the Indian study, what really happened was at 2 years after starting atropine, the mild progression was seen 87.7%, moderate in 9.7%, and severe in 2.6%. So fairly worked well. And there was a 17.4% reduction in the rapid progressors with 2 years of atropine therapy. So rapid progressors, even those who are progressing more than 0.75 diopters, did have a reduction with 0.01% atropine. So why does lower concentration atropine work better for Asian children as compared to white children? Well, because of the studies what is shown, this is the conclusion what is happening. But why is it so? Because in Asian studies, what is happening is in our Asian children, you have darker iris. So atropine, what happens, binds to melanin. So we have a slower release and a long active time of the drug. And that is why it has a higher efficacy in Asian children who generally have darker irises. So that is why our studies have shown good outcome. The Western population has really not found a significant result with 0.01% atropine. So coming to the experience with higher concentration atropine, again, this is one of the important studies where they use different concentration. If you see 0.05%, they use 0.025, 0.01, and they had a placebo group. So whenever you have a placebo group, probably it's a good way to know the efficacy of each concentration that is working. So they gave it for 2 years, and the third year was a washout period. So what they found was that almost 79.4% children needed to restart the treatment, and it was the same in each group. So with the higher concentration versus the lower concentration, you can see it's about 80 to 85%, which is almost similar. And what they concluded was that this retreatment was associated with a younger age and not with the concentration which was used here. So if you have a 4-year-old child versus a 8-year-old child, that would make a difference, but not really what concentration you are using. So it was a dose-dependent effect in each age group. So when they saw it, then this basically 0.05% was the most effective as compared to 0.01% in slowing the refractive progression, in decreasing the progression of the axial length. And it had a good tolerance over 5 years because they used it over 5 years. And they said that it should be continued for 5 years and did not find any difference in accommodative amplitude or a decrease in photopic mesopic pupil size or a dilated pupil, which was same in all the group. The problem was that it did not measure the rebound. So it's an ongoing study, but we don't know what would happen if the 0.05% atropine was stopped. Would the children go back or to the previous levels? What would happen? Or there would be sudden increase in the axial length. So if they compared the 0.01 and 0.05, no doubt it was much more effective. So 67% slowing, axial length 51% slowing, but the problem was photophobia. If you see 7.8%, so that is a problem coming up with 0.05%. So if you see another study where they compared again 0.01%, 0.1 and 0.5%. So they gave it for 2 years. Now these darker areas, if you see, these are the ones where you have a higher refractive error. So what they did, they gave these concentration atropine drops with different concentration for 2 years, and in year 3, so this is that year where they stopped everything. Now what happens is, in the 0.5%, what happens, if you see, this is the high refractive error. So you have the maximum here, almost similar here, but the least in 0.01%. So considering that because there was a greater rebound effect with the higher concentration, they started 0.01% in all the 3 groups. So when they restart 0.01% in all the 3 groups, what they found was those who had initially 0.01%, so this group, if you see this group, you can see the refractive error, high refractive error much less as compared to this and this. And so they concluded that 0.01% is clinically more palatable. So rebound has to be considered in case of every kind of treatment you are giving, because you're going to stop it at some time or the other. So basically, this is the latest study which has come up with the 0.05%. It's a higher concentration, and they did find a significant reduction in myopia progression, a significant reduction in axial length progression as well, but there was no correlation between the axial length and the spherical equivalent. And here they had a different conclusion that the response to treatment was independent of the age, whereas the LAMP study said that the age was the most important criteria. And this study, they did not find any side effects. This is again another study using 0.05%. So these are higher concentration studies, which are very few. So I've just put in just to show you what they found over a period of 2 years. Of course, just finish it. Yeah. So basically, atropine given after 2 years of placebo, the effect of age could have a role in decreasing myopia progression, because they started after seeing that there was a progression for 2 years, they were giving placebo, but didn't work, they gave the higher concentration. So they had tolerable side effects, rebound not studied. The meta-analysis is a big meta-analysis, basically that recommends 0.01% using to reduce the progression of myopia, because the side effects they were much higher with the 0.05%. And then the WHO also has their recommendations for 0.01% for 2 years. If you have good response, they say taper and stop. If it's a moderate response, that is between 0.5 to 1 diopters, you continue for 1 to 2 years. Well, if there's a poor response, that may be a response non-responder and consider alternate treatment. So those are the WHO guidelines for 0.01% as well. So coming to the end of my presentation, just a brief, so much confusion about the concentrations. Everybody must be thinking, what is the ideal concentration of atropine to be used? Well, you have higher concentrations, no doubt, they are very effective, 1%, 0.5%. But the problem is bothersome side effects and the high rate of rebound myopia. If you go to lower concentration, this has tolerable side effects, 0.05, which is being used in many studies now, but data on the rebound myopia is still not available. So that is again very important. So till date, what really is 0.05%, which has been used. It is the most effective concentration at 5 years, which has been shown, least rate of rebound myopia, and minimal side effects. So the efficiency of atropine is dose dependent, but the side effects and the rebound are still need more studies to know actually where we are going about. So how to taper atropine? Well, there are no guidelines. You could just do it. You use for alternate days for 3 months, maybe once a week for the 3 months. But remember, we are more concerned in younger children and fast progressors. So every case would be dealt differently. So I'd like to conclude here by saying that 0.01% is the only approved drug for myopia control. It's a well-researched drug. Side effects are negligible, works well in the Asian population, is cost-effective, no significant rebound. Of course, you need customization for poor responders to 0.01%, could need higher concentration or maybe use alternative form of therapy. Yes, higher concentration definitely required for younger children. But yes, remember, we need the rebound what is happening, and there are of course issues with side effects as well. Thank you.
Thank you, Professor Jaspreet, for an excellent talk. I'll now request Dr. Rishikesh Mai to present optical control of myopia progression.
Good morning. So at the outset, I would like to thank Colonel Dr. Shrikant for giving me this opportunity. I've been discussing about the treatment part of controlling myopia. We have Dr. Jaspreet has very extensively covered the pharmacological part. I will cover the optical control of myopia progression. There are no financial interest in, because some products will be shown here. When it comes to optical control, we think in terms of glasses and contact lenses. A brief has already been shared by Dr. Kavita, so I'll be going into the detail about the optical treatment now. When it comes to glasses, it is the undercorrecting myopia, bifocal or progressive glasses, or the newer generation of glasses which we call multiple segment glasses, and contact lenses, which includes bifocal or progressive contact lenses which have not been found to be that effective for controlling myopia, and orthokeratology Dr. Shrikant will be covering later on. So my job is mainly to cover the glasses, the newer generation of glasses. Before going into the details, we'll share the different theories which have been proposed for myopia progression. One is that myopia is associated with poor accommodation response, which can produce a hyperopic lag. So if you are able to correct that, you will be able to control myopia progression. That is one theory which the modalities which work on this are the undercorrecting myopia or bifocal or progressive glasses. We are more concerned with the second theory, that is the peripheral hyperopic defocus. What is this? I will be sharing shortly. But the newer modalities of glasses, the multiple segment glasses, work on this theory. The third is that in myopia there is a mechanical tension in the lens ciliary body complex. So as a result of which there is less of equatorial elongation and more of axial elongation. So So if that is able to be controlled, which is being done by, as per the theory, by diluted atropine, that will work for control of myopia progression. The fourth theory, which is a recent part, is that there are certain receptors, the photoreceptors, which are not functioning optimally. So if we are able to generate more signals from the adjacent photoreceptors, they might help in myopia, control of myopia progression, which is the newer type of glasses, or dot glasses. We don't have them in India, but that is one theory. So when it comes to glasses versus contact lenses for myopia control, the glasses have an advantage that they have a larger surface area. So a part of the surface area can be used for refractive correction, and another part can be used, the paracentral area can be used for myopia control. When it comes to contact lenses, however, the major portion is used for the refractive correction and only a small portion for myopia control. Different glasses have been tried in the past. One is the bifocal glasses in the form of executive bifocals or D bifocals, or even progressive addition lenses, PALs. Different companies have come out with different designs of progressive addition lenses. These are not the one which we use for presbyopia. They have a slightly different design. I mean, a newer PL has been launched recently in this conference also. I'm not remembering the company, but overall, I mean, in the past, the PALs or even the bifocal glasses have not, I mean, their results are equivalent to single vision lenses. So that is why necessity is the mother of invention. So we came out with a new theory, which is called the peripheral hyperopic defocus. Now what this is, that the parallel rays of light, they normally focus on the retina. In myopia, they are focused in front of the retina. But what happens to the peripheral light rays? It is believed that in myopia, the peripheral light rays, they focus behind the retina, so thereby producing a hyperopic defocus. Now retina tends to seek the point of focus, so that is why there is an axial elongation. If we are able to convert this hyperopic defocus into a myopic defocus by placing some kind of plus lenses in the paracentral or peripheral part of the glasses, they will produce a myopic defocus, as a result of which the axial elongation will not take place. This is the theory on which most of these multiple segment glasses are based upon. So they all these lenses have a common design. They have a central area for refractive correction and a paracentral area which consists of hyperopic lens segments, either hyperopic glasses or astigmatic lenses. So there are different designs by different companies. DIMS is one of the type of multiple segment glasses which are called defocus incorporated multiple segments. They are being marketed by Hoya company. MyoSmart is the name. No financial interest, obviously. So they have a central refractive zone and a paracentral honeycomb appearance of +3 diopter or 3.5 diopter defocus glasses for peripheral myopic defocus. So these glasses have been there since quite some time, and lot of research has been done, and it has been found to be effective in 62% of the lenses of the cases. One of the important studies was done in China. They have studied the children for 2 years, 3 years, and recently for 6 years. At the end of 2 years, they found that in terms of spherical equivalent change and in terms of axial elongation, both the I mean the DIMS overscores over the single vision lenses. So no doubt that DIMS does work. So they studied the same set of patients over 3 years, but at I mean what they did was, after 2 years they converted all the single vision patients, single vision lenses patient into DIMS. So they found that for those who were on DIMS for all the 3 years, they had good myopia control. More important is those who were on single vision lenses for the first 2 years, when they were converted into DIMS in the third year, the control of myopia is significantly more, as it is seen from the first of the row, both in terms of spherical equivalent and in terms of axial elongation. This study, I mean this same group, they studied their effect over 6 years later on. This was published in 2023 or 24, and in this what they did was they divided patients into 4 groups. One is those who were on DIMS, those who were initially on single vision and then on DIMS, and after some time some patients, they dropped out, they opted for the single vision lenses. So they wanted to study the rebound phenomenon also. So the important conclusions from this study was that there was a sustained myopia control with the DIMS glasses over a prolonged period of time, that is 6 years, and definitely it works better than single vision lenses. Those who were converted, the third and the fourth group, they converted back to the single vision lenses, but they did not have any rebound phenomenon. And also the other optical side effects like optical aberrations or spherical aberrations were not seen with DIMS over extended period of time. Coming to the second type of glasses is the HALT, that is called the highly aspheric lensless segment or lenslet target. These lenses are by Essilor. I think the name is Stilest. So these are these are also available in India. Again, they have a central optical zone and peripheral or paracentral aspheric lenslet zone. If you want to see, they appear like a single vision lenses, both DIMS and this. So if you put a camera flashlight over a white background, you will be able to see those concentric lenslet segments. The inner ring has around 28 and the outer ring has around 157 lenslets. They have, according to the studies, again one important single center trial, they, in 157 patients, they found they had 3 groups. One is the single vision lenses. They initially tried small aspheric astigmatic segments also, that is SAL, and then the high aspheric lenslet, and they found that HAL, the third group, they had the best outcome in terms of myopia control, both in terms of spherical equivalent and axial elongation. So they studied this group over 5 years. This is a recent study which has come out, and they found that over 5 years also, compared to the extrapolated single vision glasses, due to paucity of time I won't go into the details of this study, but they found that at the end of 5 years, again HALT glasses, they have a better outcome in terms of myopia control compared to the single vision lenses. So over a prolonged period of time also, they have a good effect. So important conclusions as far as these two types of glasses which are more commonly used is that when there is a difference in the wearing time according to the studies, it has been found that the increasing the wearing time of HALT glasses has better myopia control, but when it comes to DIMS glasses, it doesn't happen like that. So even if the child is wearing for 5 to 6 hours, he will have a good myopia control also. Starting optical treatment earlier in age has been found to be better outcome compared to older age group, and it has, according to Mark Bullimore et al., they have suggested that though these studies are in East Asia, you can extrapolate it to other ethnicities also. Obviously, if one therapy is not working, you can go for combined therapy also. The third type of, these DIMS or HALT can be combined with optical treatment or orthokeratology also. The third type of lenses are the KARE lenses, which are called cylindrical annular refractive elements. They are being marketed by Zeiss company. So again, they have a central, the refractive zone and the paracentral concentric rings, just like our multifocal lenses. And according to one study, the effect has been not as good as with the other type of lenses which has been studied. The fourth, DOT glasses, they have not come into the market so far. They are studied in the, in Britain. They are called diffusion optic technology. It is slightly different from the other 3 lenses which I just described. They have in the paracentral zone, they have something called diffusers. Now, they are believed to be working on a theory that they in myopia, there are certain photoreceptors which are not optimally working. So they these diffusers, they suppress the abnormal cone stimuli and increase the contrast signaling, thereby preventing axial elongation. According to their study, they have been found to be very, very effective. So let us see what happens when it comes to India. When you compare these glasses with low dose atropine, definitely, just a minute please. The ease of use with glasses is much more. If you can't, if you expect a child to put drops every day for 2 or 3 years, slightly difficult compared to just wearing glasses. The only problem is all these studies are single center trials. So according to Radhakrishnan et al., a multi-center trial have been tried, but not as extensively studied as with diluted atropine. Coming to the cost factor, because India is a cost effective market. So if you compare these two, the diluted atropine versus multiple segment glasses, at the end of 2 or 3 years, the cost of therapy is not different. But yes, definitely low dose atropine is cheaper than the glasses. So with this, I would like to conclude by saying that these glasses or multiple segment glasses are effective, at least in 62% of cases. They don't have any pharmacological side effects or rebound phenomenon once you stop wearing using that treatment. These are my references. Thank you.
Started. Oh, thank you, Dr. Rishikesh, for an excellent talk. I'll now cover role of overnight orthokeratology in myopia management and its control. Orthokeratology is a simple, safe, non-invasive, highly effective US FDA approved technique for management of myopia, but is much less known and even less practiced amongst ophthalmologists. To highlight the importance of orthokeratology in improving the quality of life in children, I'll present a few cases. My first case was a 16-year-old girl who was a marathon runner. Her unaided visual acuity was 6/60 in right eye and 3/60 in left eye. She had a myopic astigmatism. Spectacles were a major handicap for her, as it would affect her performance in the races, as she had to continuously wipe the glasses, whatever sweat was falling on the glasses. So I managed her with orthokeratology, and she went on to win a 50-kilometer run and an award of 50,000 rupees, and was also selected for the Asian Games. Another patient, 17-year-old boy, was a national level golfer. His vision was 6/36 unaided in both eyes, and he had a myopia of 2.75 diopters. His requirement was a clear natural vision without spectacles or contact lenses. On treatment with orthokeratology, he went on to win an award of 2 lakh rupees in a major tournament. A 19-year-old girl had come to me when I was in Jammu. She came for treatment of calazion and removal of glasses. Again, her vision was 6/36 in both eyes with a myopia of 2.75 diopters. I prescribed the lenses to her, and next I saw her in the movie No One Killed Jessica. Now, this 14-year-old boy was a complex case. He had a mixed astigmatism, and such cases don't respond so well to orthokeratology normally. So I was a little reluctant to prescribe him glasses, but he had come to me with a lot of hope, having visited all the centers in Delhi NCR. His main problem was he was interested in sports, and he would play football, basketball, badminton without glasses and would frequently get hurt. So on treatment with orthokeratology, he's improved to 6/9 both eyes, and his quality of life improved, and he has been under follow-up for last 8 years, and recently he has undergone contour LASIK. So orthokeratology is a very effective modality and is particularly useful in children and adolescents, as the option of LASIK is not there. It's the science of changing the curvature or shape of the cornea to change how light is focused on the macula. We all know that the refractive power of cornea is about 43 diopters, and being the first refractive interface, it harbors most of the eye's corrective power. So manipulation of cornea can help in treating myopia, and this is the basis of orthokeratology and various corneal refractive surgical procedures. Orthokeratology acts on the 50 micron thick epithelial layer, which is a continuously regenerating layer. The compression force required to induce change in the corneal epithelium is very minimal, and being the first refractive interface, it brings about a major change in power and hence is comparable to LASIK. High success rates have been achieved with reverse geometry lens designs, high oxygen transmission lenses, and overnight wear. This is the design of the orthokeratology lens. You can see that the base curve is flatter than the cornea and exerts a gentle compression on the corneal epithelium. The second curve is the reverse curve zone, which has the space between the lens and the cornea, which sucks in the tear film and creates a negative suction force and allows the intracellular fluid also to move. This brings about the thickening of the corneal epithelium under the reverse curve zone and thinning in the central optical zone. The next are the two alignment curves, which help in the centration of the lens on the cornea, and the last is the peripheral curve, which allows the tear film exchange. So this is the orthokeratology lens placed onto the cornea, and this is the ideal fit. You can see that each ring of fluorescence is concentric to each other. So when the lens is placed on the cornea, initially the corneal epithelium is of uniform shape, and over a period it gets compressed in the center and thickens under the reverse curve zone. This corrects the myopia. So while the patient is asleep, as these are overnight wear lenses, the lens changes the surface of the cornea. On waking up, once the lens is removed, the myopia is neutralized and the patient can see clearly throughout the day. Over a period, the epithelium again swells up and comes back to normal, and it's time to place the lens again back onto the cornea. This animation will make it more clear as to how orthokeratology acts. You can see as the lens is placed on the cornea, it exerts a gentle compressive force onto the central corneal epithelium. Over a period, the epithelium gets compressed in the center and it gets thickened under the reverse curve zone. In the morning, once the lens is removed, the patient is able to see clearly as the myopia is neutralized. So the ideal candidate for orthokeratology is a juvenile to adult myope with -1 to -5, and almost it works in -6 diopters also. A normal spherical lens can neutralize up to 2 diopters of astigmatism, and toric orthokeratology lenses are available which can correct up to -4 diopters. And it's ideal for sports person, people working in dusty areas, and so on. This lens works like magic. Within 1 hour, most of the myopia is neutralized and most of the patients achieve a vision of 6/6, especially mild to moderate myopia patients. 70 to 80% of reduction takes place with the first night of wear lens only. Maximum effect is seen at 3 weeks, and after that the patient can titrate how long he should wear the lens. The effect usually lasts for 2 to 5 days, and the patient can wear once in a week or once in 3 to 4 days also. Low myopes get a better effect. So it's a safe, non-invasive, cost-effective, reversible technique suitable for children, and most importantly, it does not require any expensive infrastructure, and it has been shown to slow down the progression of myopia. So how does it help in slowing down the progression of myopia? I've already shown this slide earlier. This lens converts the peripheral hyperopic defocus into a myopic defocus. You can see that the thickening of the corneal epithelium takes place under the reverse curve zone. So while the patient is wearing the lens, the rays traveling through the reverse curve zone come to a focus in front of the retina, leading to a myopic defocus. And once the lens is removed, the thickened corneal epithelium, this ring of thickened corneal epithelium, creates a myopic defocus. As a result, this myopic defocus is sustained throughout 24 hours. And this sustained myopic defocus helps in controlling myopia progression. And this has been brought out in various studies. The first study was LORIC in 2005, which showed that it has a preventive control on myopia progression. But at that time, it could not say whether it was any predictable effect in individual cases. Then came a meta-analysis in 2015, which showed that orthokeratology is effective and acceptable for slowing myopia progression. And they suggested that an early intervention should be done to reduce the prevalence of high myopia. The ROMEO study in 2012 first documented that it slows down the axial elongation by 43% and reduced the fast progressors from 65 to 20% in subjects in the age group of 7 to 8 years. And it also suggested that it would be beneficial to commence ortho-K treatment in younger children. Another meta-analysis published in Current Eye Research compared orthokeratology with spectacle lenses and showed that it had a significant efficacy in controlling axial elongation. It showed that better effect was seen in Chinese children and those with initial high myopia. Recently, another study came for combination treatment with atropine and orthokeratology, and it has been shown that both orthokeratology and atropine have a synergistic effect, and if combined with 0.01% atropine, it can have effect similar to 0.05% atropine. In high myopia, orthokeratology doesn't completely reverse the myopia, it only causes a partial reduction. But even in such cases, the myopia control effect is there, and it was shown that in these partial reduction cases, axial elongation was reduced by 63%. Similarly, toric orthokeratology lenses have also been tried, and at 24 months, it has also shown that the progression was 52% slower as compared to the control group. And this correlated significantly with the initial age of the subjects. So orthokeratology not only reverses the myopia, but it also slows down the progression of myopia. It's the bridge towards effective myopia control. Thank you. Yeah, so the house is now open for questions. If you have any comments or questions, you could ask. We have 3 minutes left in the course. No, a well-fitting lens. You have to be sure when you have to do a orthokeratology trial, it's a 1-hour trial. Once you get the ideal fit, then you prescribe those lenses. An ideally fitting lens will not cause any problem. And these are high decay lenses, and these are approved for overnight wear. So it doesn't cause any damage to the cornea because oxygen transmission is good. Supplies, there's a company, Lucid Korea. It has placed a stall here in this exhibition itself, and we have the Indian distributors here.
How young the child should be so that you can prescribe orthokeratology?
I have a number of children of 7 to 8 years age group also, and I've realized that the patient really respond to it very well. You need to train them first, and you need to train the parents also, either mother, usually it's a mother who accompanies the child, and you have to be sure that they can handle the lenses. The hygiene is of utmost importance. That is the only thing you are scared of. So you have to first counsel the patient, make them practice in front of you. Once you are convinced that they can handle the lenses at home on their own, then only it should be prescribed.
Have you encountered any complications like corneal complication or dry eye, or do you prescribe any artificial tear in these cases?
When we do orthokeratology workup, we normally don't prescribe these lenses if the patient has dry eyes. And in any case, lubricants are given because they help in helping in placing the lens and removing the lens from the eye. So when we are placing the lens, we place a drop of tear substitutes onto the lens, and then we place the lens on the cornea so that it smoothly fits placed on the cornea. And in some cases, it happens that in the morning the lens is adherent to the cornea, it doesn't come out very easily. That's why these days 5-curve lenses. This was the problem with the 4-curve orthokeratology lenses. In 5-curve lenses, another alignment curve has been introduced to remove this problem of adherence. So in the morning, it's better to place 1 drop of artificial tears in the eye, ask the child to blink or the patient to blink 2-3 times, and then you remove the lens, then it becomes easier.
Thank you. This is a question for the panel. So I do mostly ROP cases, so they end up with myopia. So what is your suggestion about dealing with the child in the future myopia?
Yeah, so whenever you're prescribing these interventions for progressive myopia, that is one thing you have to rule out. It should not be ROP, not should be syndromic myopia, should not be congenital high myopia, should not be prematurity. So these are things where you don't use any kind of intervention because that's a lenticular thing. You have, in ROP, the myopia is lenticular because of the anterior segment arrest. So the axial elongation is not much. I mean, the maximum it will reach is about 20 to 23 millimeters, which is normally metropization. And the myopia usually start, its axial myopia, it will usually start after 23 millimeters. So in ROP, not of much use. I mean, it's like having an initial high myopia because of a because of the lens, and probably trying to stop that 20 to 23 millimeter elongation if you give atropine. That's not really required in these cases. So it's not an axial myopia, it's a lenticular myopia in ROP.
So traditional glass is the only way to
Yes,
way out.
yes.
Thank you.
So I
Even
thank you all.
glaucoma is the same thing. We all have high myopia and glaucoma also, congenital glaucoma. There also I don't think it's recommended.
So I thank you all for a patient hearing. If there are any more questions, we'll take it outside.